Welcome to Reboot with Dr. Arasi Maran. I'm your host, Dr. Arasi Maran. I'm a board certified interventional cardiologist with more than a decade of practice. I work at the Medical University of South Carolina, but this podcast initiative is completely separate from my faculty responsibilities in the university. The goal of this podcast is to bring you evidence based science so that you can choose what's best for you and have the right resources to do that. Today is a fantastic episode. I'm looking forward to it. We've tried to do it for a long time, and for multiple reasons, it got rescheduled, and here we are. I have with me Dr. Nancy DeMore. Dr. Nancy DeMore is a distinguished professor of surgery and holds the prestigious BMW Endowed Chair in Cancer Research at the Medical University of South Carolina. She is also the co-leader of developmental cancer therapeutics at the Hollings Cancer Center, a role that underscores her leadership in advancing cutting edge cancer research. Dr. DeMore has remarkable 20 plus years of experience as a breast surgeon, during which she made magnificent contributions to clinical care and surgical innovation. However, her current focus has now shifted entirely to research, where she is dedicated to pioneering the development of novel therapies aimed at treating breast cancer. Throughout her career, Dr. DeMore has been involved in more than 30 clinical trials, making critical contributions to the translation of laboratory discoveries into real world treatments. As a result of her expertise, she serves as the active reviewer for the National Institute of Health, NIH, helping guide the direction of cancer research funding. In addition to a clinical and research role, Dr. DeMore is the program director of the Medical Scientist Training Program at the Medical University of South Carolina, where she mentors the next generation of physician scientists. Her passion for bridging the gap between scientific discovery and patient care has led to co-founding Innova Therapeutics, where she currently serves as its chief scientific officer. Innova Therapeutics is dedicated to translating cutting-edge research into new drug therapies for cancer patients. Dr. DeMore earned her medical degree from Chicago Medical School and has completed residency in surgery at the Boston University Medical Center. She further owned her expertise through cancer into cancer research at a research fellowship at the Harvard Medical School, followed by fellowship training at the renowned Memorial Sloan Kettering Cancer Center in New York. Her work continues to shape the future of breast cancer treatment, combining decades of clinical experience with the latest advancements to improve patient outcomes. Nancy, my jaw is just hurting from your introduction. What an accomplishment. What a magnificent career you've had. And welcome to the podcast. I'm so honored to have you here with me.
Well, thank you for that kind introduction, and I'm very happy to be here.
So, Nancy, let's start off with your journey. I mean, I read a lot of your accolades, but tell me, what was the journey like, and kind of talk us through how you got to where you are right now.
Sure. Well, it started in college when I was doing research with a professor who was studying a field called tumor angiogenesis. And what that is, we know that for tumors to grow, they need a blood supply. And so it's discovering what are the factors that cause blood vessels to encroach on the tumors to allow them to grow. And the leader in that field was Dr. Judah Folkman, who was at Harvard. And I read all of his papers, and I called him and I said, gee, I'd love to work in your lab. I have 6 weeks off in a couple weeks. Can I come rotate with you? And he said, well, I get about 200 applicants a year, so it'd be good for you to apply about 2 years in advance. And so I kept that in mind. And I went to medical school in Chicago, and I fell in love with surgery. I just absolutely wanted to be a surgeon. And when I matched at Boston University, the day after I matched, I called Dr. Folkman and I said, remember me from, 5 years ago? I'm applying 2 years in advance, and he accepted me. And so I spent 3 years in his lab in between while I was doing my general surgery residency, took 3 years off. And those 3 years were really instrumental to developing a strong scientific background and really getting involved in cancer research and in breast cancer research and drug development and entrepreneurship. All of those really started at that time. And he really emphasized the importance that what we were doing in the lab, we had to get out to patients because patients were calling him all the time that had no hope. And there were patients that were dying. And he really emphasized that importance of the translation. What we're doing in the lab is not just for science sake or because it's interesting or because it's fun. We are doing this because we need to develop cures for patients. So I went back, finished my residency, loved surgical oncology, did my fellowship in New York, and then started my first faculty position as a physician scientist at UNC Chapel Hill, where I worked as a breast cancer surgeon. So I saw patients, I operated, and I also had an NIH-funded lab. And seeing my patients every day, many people do very well, but there are some people that, develop metastatic disease. And that was really the inspiration for me to keep going in drug development. And when I was at UNC, I really started the fundamentals of my research, which has now spanned over 18 years. And I discovered I discovered a novel function of a protein called SFRP2, that this was involved in tumor growth. And my whole career has been showing its mechanism, how it causes tumor growth, the variety of tumors it's involved with. And we developed a drug that works in our preclinical models at multiple types of cancer. And so we're now at the point where we are trying to get the funding to get this into the first in human clinical trials.
Oh, wow. It's amazing. I'm looking forward to seeing everything that comes out of your lab, and kudos. What an amazing accomplishment, and what a beautiful journey it has been,
Thank you.
seriously.
Thank you.
But, we're going to kind of go back from where you are at the cutting edge research to the basics of breast cancer.
Absolutely. Yeah.
For my listeners who are kind of like, what is breast cancer? How does it develop? Who are those people who are at risk? That's where we want to focus on. So, can you kind of tell me, breast cancer, what is the first sign of breast cancer in general?
Sure. So many breast cancers are detected by screening mammography, so there are no symptoms. But I will talk about, if something is larger, what the symptoms are. So if somebody feels a lump in their breast, they need to get that evaluated. There are lumps that can be benign, non-cancerous, but you really don't know until you get imaging and a biopsy. If there's any changes in the skin, sometimes cancer can have involvement in the skin. Changes in the skin do not always mean cancer. It could be an infection or something else, but certainly any new redness needs to be evaluated. There are some tumors where the breast actually shrinks. So if you actually see, you were symmetrical and now you see something shrinking, that's real important. There can also be some other tumors that do rapid enlargement in the breast, or if you feel under your armpit a lymph node. And every sign that you see in the breast might not be cancer, but you should go immediately to your doctor because you can't tell without a workup and a biopsy. But hopefully it doesn't get that far and cancer can be detected before you have any symptoms through breast cancer screening.
So, you talked about breast cancer screening, but not everyone is aware at what age they should start screening. That's number one. Not everyone goes to the primary care physician when they are otherwise healthy to even talk about problems. So, when does screening start?
For the average risk woman, breast cancer screening should start at age 40. There was a lot of controversy. Some groups said 50, but I think now it's really been a consensus to start at age 40. And to have screening yearly is what we recommend at MUSC and what many societies recommend. And it has been shown that screening actually saves lives. So when they compared a group of women who was screened and developed breast cancer to a group of women who was not screened and developed breast cancer, the group that was screened had a 15% improved survival. We give chemotherapy, really hard drugs, to get a 15% improvement in survival. And you can get that just by having breast cancer screening. And screening is really mammography. Unfortunately, self-exams by physicians and by patients, although we don't discourage them, the data has not shown that improves survival. The thing that improves survival is screening mammograms. So that's the average risk woman is age 40 and yearly. there are women who are at high risk. And so we,
So before you go
yes,
on to the high risk
sure,
women, why
yes,
don't you tell us what are the high risk features? Who are the
sure.
people at high risk for breast cancer development?
So about 10% of patients with breast cancer actually have a genetic mutation. And people actually think it's larger than that. It is only 10%. And those are genetic mutations in genes. The common ones people may have heard about from famous people having these mutations are BRCA1 and BRCA2.
Hmm.
There's other genetic mutations that put someone for high risk. So we get suspicious that someone could be in a family that has that by the following. If there are young women who have breast cancer, if there's multiple family members with breast cancer, if there's a history of male breast cancer or a history of ovarian cancer, those are all warning signs that there could be a genetic mutation in the family. And it's a simple either blood test or cheek swab to test for these genetic mutations. So it's really important to know, because if someone does have them, they can be at very high risk, sometimes up to 80% chance of developing breast cancer, sometimes not as high. So that's one category, is the people who have genetic mutations. There are other categories. You can be at high risk and not have a genetic mutation. Just having a first degree relative with breast cancer does increase your risk. First degree would mean your mother or your sister or your daughter,
Hmm.
or your father. Of course, men can have breast cancer as well. So first degree relative increases your risk. There are other risks. If you have your first period when you're young, under 13, if you go through menopause late, if you have a child after age 35, if you've been on oral contraceptives for over 10 years, are all risk factors for breast cancer. And if you have a primary care physician, there are some very simple computer models. One is
Hmm.
called the Gale model that your physician can put in your characteristics to see if you're at high risk. And the average risk of someone developing breast cancer is about 12% lifetime risk if they live to age 90. We consider someone to be at high risk if they're 20% or more lifetime risk. So that's what we're talking about when we say high risk.
Nancy, I'm going to stop you right there. I love that. So, average, like, so all of us, men and women, are a 12%,
No,
are a 12,
women. Women are
just
12%.
women. Oh, okay,
It's
okay.
very rare for male to have, only about 1 in 100 cases of breast cancer occur in a man. So it's
Okay.
very rare for a man to have breast cancer. It can happen, but for women, the lifetime risk is 12%.
So lifetime risk is 12%,
To
and
live,
remember,
lifetime meaning if you were to live to age 90.
age, okay, is about 12%. And if it goes above 20% is when you are considered a high risk for
Yes.
breast cancer, and your screening is completely different from the
Yes.
average risk patient
Yes.
person.
Yes. And what happens then, in addition to getting yearly mammograms, it's recommended to get a yearly breast MRI. A breast MRI works differently than a mammogram. A breast MRI is looking at blood flow. And again, tumors require new blood flow, the whole process of angiogenesis. So and they're more sensitive. They miss less cancers than mammogram.
Mm.
So you can say, well, if they're more sensitive, why doesn't everyone get it? For several reasons. One, they're more sensitive, but they're less specific. What that means is there's more false positives. So you may get an MRI and you get a phone call. We see something that looks suspicious. Now it's time to panic. And
Yes.
then you get an ultrasound and a biopsy and say, no, 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 it's benign. So
Yes.
that is more common if you get an MRI. And that, is can be, a problem, because you go through a biopsy and, it could
Of
be
course, it's an
painful and things like
invasive
that. Right.
procedure,
So
and
it's
yeah.
only done, and it's also much more expensive. An MRI is much more expensive than a mammogram. But so that's why it's only done in the high risk population. So you get a mammogram and an MRI. It's good to alternate them every 6 months. That way your breast is being imaged, and also to follow in a high-risk clinic and have a physical exam once a year is important as well. And so that's what we have for screening. We also have some options for prevention.
So let's move to the prevention side. Okay, yes, early detection is great,
Yeah.
but an ounce of prevention is worth a pound of cure. So, what are the prevention strategies available?
So there are two medications that can prevent breast cancer. One is called tamoxifen, and this is a pill that blocks estrogen. This can be used if someone is both premenopausal or postmenopausal, and you take it every day for 5 years. And it's been shown to reduce your chance of getting breast cancer in half, which is a lot, by
Yeah,
50%.
but
There
this is
are,
only for the high risk group.
right, this is right, yes. I'm talking prevention for high risk. There's another medication called Avista, which has less side effects than tamoxifen, and this can work in women who are postmenopausal. So there are medications that can be taken. For people who have genetic mutations, if you recall, like Angelina Jolie had a
Yes.
genetic mutation, had a double mastectomy. That is an option, and that's really not considered drastic when you see that this family, these women have had so many people around them have breast cancer, and if they have the mutation, they can have a 50 to 80% chance of developing breast cancer. And so having both breasts removed, and that this can be done now with plastic surgery reconstruction, is an option, and that reduces the chance of breast cancer by 99%. So that's kind of at the extreme for those women with the genetic mutations.
So, for the average risk patient, average risk female patient, let's just label that, because we are talking about, right now, when we're talking about breast cancer, we're talking about women and breast cancer. What are there anything, lifestyle wise, which they can do to reduce this 12% risk?
So there are a lot of lifestyle things that can improve your overall health that are extremely important. Um, There haven't been studies to show that these actually reduce your risk of developing breast cancer, but they're very important. It is extremely important to be health conscious and to exercise and to eat a healthy diet, lower in fat, lower in sugar. All of these things are really important for overall health. Um, and exercise is really important. But in terms of having large national studies that show that they actually reduce the risk of breast cancer, we don't have that. Um, but being healthy, it's interesting. This is a really interesting fact. The number one cause of death in a breast cancer survivor, so this is someone who has completed their breast cancer treatment, they're out over 5 years, the number one cause of death is cardiovascular disease.
Yes, I
So this
believe
is
that.
really, so when I say, right, we can't just say, we are a whole person.
Hmm.
And so I can't, say enough about a healthy lifestyle that includes exercise and good nutrition. But the large national randomized studies have been in the high risk group and have been these medications that reduce the risk of breast cancer.
We hear about different things, and I truly like to get your opinion on those. Like, I've heard about hair dyes causing breast cancer, acrylic nails causing breast cancer, alcohol consumption causing breast cancer, deodorants causing breast cancer, bra wearing causing breast cancer. Can we talk about each one
Yeah.
of them?
Well, I think we can talk in general. So I want to talk about the different types of studies that there are.
Hmm.
There's epidemiologic studies. And what those are is investigators will look at a large population and they'll find out what they were exposed to And then they'll see who developed cancer, and they may find that people that had certain activities had a higher risk of developing breast cancer. So when you're hearing about all of these things, these are from epidemiologic studies. I see these as hypothesis generating. Okay. To prove something causes cancer, you need to do more of well, a randomized study, where you would put half of a group into one and half a group of another and see what happens to them.
Hmm.
Though, and so that's why you hear about so many things, and then you hear another study that says it's not true. It's just a different type of studies, and these are epidemiologic studies, and they come out and they find associations between certain activities and an outcome. They are not proof that that activity caused that outcome. And um, so I think that what you have to look at is how many studies showed it. Was it one study, or was it reproduced by multiple investigators? If something shows up multiple times, that's a higher chance of something happening. Let me give you an example of what I'm talking about. It used to be thought that hormonal replacement therapy improved the risk, improved survival. It reduced cardiovascular disease.
Hmm.
And actually, and there were some thoughts that there could be, it didn't have an effect on breast cancer. And in those studies, it turns out that the woman that took hormonal replacement therapy, it turns out happened to be, they had a higher education level and they took better care of themselves. And that is also associated with improved outcome for cardiovascular disease. When they did a randomized trial of hormonal replacement therapy versus not, it turned out the woman with hormonal replacement therapy did not have a better cardiovascular risk. In fact, they had an increased risk of stroke, and the hormonal replacement therapy had a higher risk of cancer. That's the difference between one of these epidemiologic studies versus actually a randomized trial, one treatment versus another. And that's why when this goes to the general lay people, they get so confused because they're not told what type of study was this and how much faith should we have in it.
So, what is the verdict for hormone replacement therapy and breast cancer?
The verdict is that it is definitely associated with an increased risk of developing breast cancer. And it does not protect against heart disease, and it does have an increased risk of stroke. So we do not recommend long-term treatment with hormone replacement therapy. There are now other drugs that can handle symptoms of menopause. There are drugs for hot flashes. One drug is called Effexor. And so when I was talking to a woman, I would say, well, what are your symptoms? And let's look, are there other medications or lifestyle changes that you can do to control these symptoms? And if someone is going to go on hormonal replacement therapy for menopausal symptoms, it's best to do it just for a short period of time. But we don't want women on hormonal replacement therapy for years. That does increase the risk of breast cancer.
So, you say that, but there are, honestly, I've had people on the podcast who are focusing. I mean, menopausal treatment has just exploded. There are like people who are psychologists, psychiatrists, internal medicine doctors, all take the menopausal certification exam. And because of the telehealth boom and everything, it's exploded into it. And I honestly find the data very confusing. I find the data very confusing. The strokes and everything was also in people who had other risk factors and other things which put them at higher risk for clots in their legs and stuff like that. And I also, estrogen and progesterone is something I've always been scared since medical school. So I don't like to delve into those hormones if I don't have to. There's a mixed thought about progesterone only is okay.
It is, right, exactly.
Transdermal uh, estrogen is okay. Can you split that up for me?
Um, So I think ultimately a woman has to talk to her doctor about it. There are, nuances which way you give it, and I'm not going to go into all that.
Yes, I'm not talking about that.
Um,
Yes.
I think that you also have to look into this. Are you someone who's at increased risk for breast cancer
Hmm.
versus average risk? I think that goes into it, because if you're at increased risk, we want to give you drugs that block estrogen. So and I think that I I'm a big advocate of, our job as physicians are to educate patients, and it's a patient's role to make their own decisions, right? So someone could say, okay, my symptoms are so terrible, and I understand that this might increase my risk by this much, but this is going to greatly increase my quality of life. So I do think that the best thing is for one-on-one counseling with a person's physician. And you're right, it's not a one size fits all.
Hmm.
I mean,
Hmm.
because if someone's life is going to be ruined because of their menopausal symptoms, and they've tried other medications and it doesn't help, and you're right, there are certain types of progesterone only that don't have that increased risk. So it is a whole topic in and of itself.
Yes.
Um, but
So
and
I
I
think,
think my point was the difference in outcome based on the type of the trial. A retrospective trial, right, gives you a totally different result as a prospective, which means that you're starting and you're assigning half a group to this treatment and half a group to that treatment, versus the studies where you're just looking back at things that happened in the past. And so I'm trying to explain that the reason why there's so much out there that it's hard for people to understand is because these studies are designed very differently.
I
And
mean,
so
what
I can't, yeah, I can't say if hair dye is going to increase. I mean, there certainly
true.
are studies that show it's associated with it, or the hair straighteners.
Yes. So it's basically the point I think you're trying to make is correlation is not causation.
That's
And we
it. Thank you.
truly don't have enough uh, hard facts to tell us this is what is happening there. And, and we just need more, we need to watch for more.
Right. And I would say common sense, if something is not going to greatly interfere with your life, avoid it,
Yeah,
you know.
absolutely, absolutely. Now, now let's flip into the journey of a woman who gets a mammogram which is positive. What
Sure.
happens? What would the next step be
Sure.
for her?
So the things that we look for that are abnormal in a mammogram could be calcifications, or a mass. And so if there's an abnormal mammogram, the standard screening is two views. They're going to get called back, and they're going to have multiple different views so that they can magnify the area and get a good look at it. And they're also going to do an ultrasound, because a mass on a mammogram, they can't tell if it is a solid mass or a cystic mass. So an ultrasound will tell if it's solid or cystic. A solid mass is going to need a biopsy. A cystic mass does not always need a biopsy. Sometimes it can be just a pure cyst, and the radiologist will say, it's just a cyst, you're fine, you're done. Um, if something looks suspicious on the imaging, and they're also going to do an ultrasound of the lymph nodes as well, then they'll go ahead and do a biopsy. And generally, the way that the biopsy is done is in radiology. It's called a core biopsy. It doesn't require a surgical procedure. If they see the image on ultrasound, then you'll lie on your back, and they'll clean off the skin, and they'll give you some numbing medicine, and they'll put a little needle in, and it will take a piece of that tissue. If they don't see the lesion on ultrasound, then they'll do it, what's called a stereotactic biopsy, and that's where they do it by mammogram. So you actually lay on your front with your breast hanging down, and they'll go ahead and they'll do the biopsy. It's mammographically guided. And again, just a little piece of tissue, just a little nick in the skin. And they'll get the biopsy results a few days later.
And so I don't know whether you know this, but I started my career as a surgeon, and of course mastectomy was like a big procedure and all of us wanted to learn it, and the lymph node dissection, blah blah blah. But is like total mastectomy the only treatment? What are the
Yeah,
treatment options? I know
sure.
there are hormonal types of cancer, but if you
Yeah.
have to simplify it.
Yeah. So if somebody is diagnosed with breast cancer, the things to think about are surgery, if there's any role for chemotherapy or hormonal therapy, and radiation. And in terms of surgery, right, historically, it used to be that removing the whole breast was the only way to go. If the tumor is contained and is not very large to one location in the breast, it's completely fine to do a procedure called a lumpectomy. And what that is you make an incision in the breast and you remove the tumor with a little rim of normal tissue around it. And then you don't need to remove the whole breast. In For people that are generally under 70, they should have radiation afterwards. There's clinical trials of omission of radiation, but in general they get radiation, and that's usually 5 days a week for 6 weeks. It used to be that women who were over 70 also got radiation, but if the tumors are small and hormonally sensitive, sometimes they don't need radiation. So there were clinical trials where half the women got mastectomy and half got lumpectomy and radiation. And what was found, even over 20 years, is that there was no difference in survival.
Hmm.
So if someone says, I'm young and I've got kids and I want to do everything I can for the best survival, doing a mastectomy does not improve survival over lumpectomy and radiation. Now, not everyone is a candidate for a lumpectomy. So sometimes the tumor will be spread out throughout the breast
Hmm.
in more than one location, and that requires a mastectomy. Or it could be a very advanced tumor involving the skin. So there's certain reasons. So there
Yes.
are reasons why people still need a mastectomy. If it's now, one thing is if someone comes in and let's say they have a larger tumor, 4 centimeters, and they have a small breast, and you could do a lumpectomy, but you're going to be cosmetically deformed. In people that have larger tumors, they usually get additional medications, whether it be chemotherapy or hormonal therapy first. And when people get that treatment first, many times the tumors will shrink down so small that you can then do a lumpectomy.
So
So,
I just want to clarify for the audience sake, mastectomy is removing the entire breast, and lumpectomy is just making a localized excision of the
yes,
tumor mass.
correct, yes.
So, I feel compared to even 15 years ago to now, the chemotherapy or the therapeutic options, like the oral therapy options for breast cancer, is advanced so
Yes.
much, leaps and bounds, where it's almost become like a chronic disease in patients where they are just on suppressive therapy. Can you talk a little bit about that?
Yeah, there have been just amazing improvements in the therapies for breast cancer. So it's important to classify. There's actually three major types of breast cancer, and they behave very differently, and they're treated very differently. So one is when they have the estrogen or progesterone receptor.
Hmm.
Those tend to be less aggressive tumors, and they respond very well to drugs that block estrogen. And these can be drugs like tamoxifen or drugs called aromatase inhibitors. And so when a woman is all done with her therapy, she's usually on one of these drugs for 10 years. And also, in some women, they can get these medications before surgery to shrink the tumor as well. Then there's what we call HER2 positive.
Hmm.
The HER2 receptor is on the breast cancer cell, and untreated, these used to be very aggressive tumors with a very high mortality rate.
Hmm.
But fortunately, there have been a whole class of drugs that block this HER2 receptor. The first one was called Herceptin, and now there's a whole class of these drugs. and they greatly improve survival. And they're given in conjunction with chemotherapy. And anyone who has a HER2 positive tumor will be considered to actually start with that treatment, with the chemotherapy and the HER2 targeted drug, and then they'll do surgery. And then they will probably receive one of these HER2 targeted drugs for a year after they're all done with treatment. So great improvement in survival with the HER2 positive. Now, the third is called triple negative breast cancer. And triple negative means it's negative for three things: estrogen receptor, progesterone receptor, and HER2 neu. And so it didn't have any known targets. And the only treatment for a very long time for these tumors was, besides surgery and radiation, was chemotherapy. And chemotherapy can be very toxic. But there has been just a great improvement of new drugs that actually work in triple negative breast cancer. The biggest one being immunotherapy. Immunotherapy works in some patients with triple negative breast cancer. There's another class of drug called PARP inhibitors, and these are for people who have BRCA mutations. And then there's some other type of antibody drug conjugates that work. And so all of a sudden, this was where we had no treatments, and now we have multiple lines of treatment. The triple negative breast cancer occurs in people of all races, but it's particularly important in African Americans because it turns out that there's more young African American women with triple negative breast cancer. And there's a higher mortality in African American women. Now, some of that may be due to social factors,
Yes,
but it's certainly
disparities. Yeah.
certainly there's a biological factor that this group of women do get the more aggressive type of breast cancer at an earlier age. And that's why it is extremely important for African American women to start at 40 and get those yearly mammograms, because early detection is really important in that group as well.
So, the fact that you guys are now using immune mediated therapy or antibody mediated therapy kind of takes us back to an earlier hypothesis, right? Is cancer a mutation problem, or is it an immune problem? Is it a metabolic disease? What is causing the cancer
It's
itself?
all of those. It's all
Okay.
of those. It's all of
Okay.
those. And so the immune, the immune system plays a big role in many cancers, but not in all cancers. So not all breast cancers have this immune infiltrate. We call some cancers hot. That means that they have this immune infiltrate, and some cancers cold. And the cold cancers that don't have the immune infiltrate don't respond to the immunotherapy.
Interesting.
So it's certain classes of cancer, and within triple negative breast cancer, they don't all get treated with immunotherapy. There are tumor markers called PDL1 that will be tested for, and only those tumors that are PDL1 positive, only those patients with tumors PDL1 positive will be treated with immunotherapy. So not all patients with triple negative breast cancer will get immunotherapy. So the immune system is very important in some tumors. Tumor metabolism is probably important in all tumors. And the genetic is there's always genetic mutations that are the kind of initial things that cause cancer. So they're all important.
So, I once had a patient who had metastasis. The cancer had spread to her lungs, and it was in her liver, and she also had a complete blockage of the right coronary artery. And the procedure to open a complete blockage or 100% occluded, it's a complex procedure. It's about 8% morbidity and mortality rate and things like that. So I was like, you have metastatic breast cancer. I really don't think we should do such a high complex procedure. And she turns around and said, I've been living with this metastatic breast cancer for 5 years. I think you should go ahead and do it. It was such a shock for me. And then I had to speak to her oncologist and understand that it is truly not the way we used to think about
Not at
cancer, which is
all.
spread out.
20 years ago, when I was doing my fellowship, we were taught that if somebody had metastatic breast cancer to the liver or lung, their survival was about 6 months. And
Hmm.
if it was to the bone, maybe 2 years. I mean, those numbers have drastically changed because of the treatments that we have. So people are living longer because of the newer therapies.
So, kind of that leads to my next question. Are we going to, or are we towards any closer to a breast cancer vaccine
Hmm,
than
that's
we
a
were
great
20 years
question.
ago?
Sure. Well, there are clinical trials with breast cancer vaccines. Absolutely.
Okay, okay.
Yes. So those are in development.
Uh,
Yes.
So
So
that's exciting. That's good news.
yes.
Now, the next question. Tell us about your research.
Okay. Sure. So, um, so I wanted to discover new proteins that caused cancer, and specifically that caused this process of new blood vessel growth.
Hmm.
And the reason was back when 20 years ago, there was a drug that blocked a certain protein called VEGF. And we thought that people were going to do great. And it turned out that it didn't improve survival. So I thought there's got to be other factors that are causing blood vessel growth that we don't know about. So I started, this was with the patient consent. I took tumors from the operating room, and I developed a technique with a laser microscope to dissect out the blood vessels from the tumors. And I developed a technique to extract the RNA so I could look at the gene expression in those malignant vessels. And I did the same thing to breast tissue from women who underwent breast reduction. So I compared tumor vessels to normal vessels. And I
Hmm.
found a whole bunch of genes that were overexpressed. I then spent a lot of time and I focused on one gene called SFRP2. And I focused on that because it had never been described in cancer. And it was a secreted protein. The tumor secretes it, which means you can make an antibody. It's easy to make a drug against it.
Hmm.
And so what we found over the years was that it is a potent stimulator of tumor growth. It not only causes blood vessels to grow, it also causes the tumor cells to grow. And recently we found it has a very big role in the immune system. And so what this protein does is it makes your immune cells not attack the tumor. Okay, so it affects multiple aspects of not only the tumor, but the blood vessels and the immune system. And we found that it's not only important in breast cancer, but it's important in multiple types of cancer. And we're focusing on pancreatic cancer and also sarcomas or pediatric osteosarcoma. There's probably other types of cancer that this is involved in, but those are the three that we're focusing right now. So we developed an antibody that binds to SFRP2 and neutralizes it. And what we have found in our animal models is that it inhibits the growth of triple negative breast cancer. And we've also looked at other cancers, particularly sarcomas. And what's really important is, especially in the sarcomas, and we're working on it in breast cancer, but we've shown this in the sarcomas, is that some of the sarcomas are resistant to immunotherapy. And when we add it together with our drug, there's a combination effect. It allows immunotherapy to work. So that's pretty big because it can take a tumor that was resistant to immunotherapy and make it sensitive, at least in our preclinical models. And so we want to go ahead and get this into the clinic. And so all this research has been funded by the NIH, the Department of Defense, foundations, MUSC, UNC, and so up to this point, you can get all your research done with those sources.
Hmm.
But for us to produce the antibody for the clinical trial is $6 million. And for us to get, we're talking like over $10 million to get into the clinic. And so that's why we formed Innova Therapeutics, so that we can go ahead and raise funding to get this into the clinic. And so once we raise our funding, then we'll go ahead and go through all the steps to enter into clinical trials.
Oh my God, that is fantastic. Dr. DeMore, I want to truly thank you so much for sharing your wealth of knowledge and the groundbreaking work with us today. I have learned so much just from this podcast discussion. I never knew that an average woman has a 12% risk of breast cancer if the average woman lives up to 90. Nor did I know that high risk is considered only when you are at 20% or more at risk. And I knew mammogram was doing a great job in detecting early breast cancer early, but I did not know it actually had survival benefits.
It does.
And, all that is like fantastic information. I think that one topic that we did not discuss, and, if you have the time to briefly touch upon, is male breast cancer.
Sure. Yes. So as I said, about 1% of breast cancer occurs in men. And it turns out that when a man is diagnosed with breast cancer, it's usually diagnosed at a later stage because there's usually more delay in diagnosis. And so male breast cancer generally behaves the same as breast cancer in women. It's just when you're diagnosed at a later stage, that is associated with the worst survival. So it's really important if a man feel a lump in his breast that he see his doctor. And what's important to know is that we do a physical exam, and physical exams are important, but you really need imaging. Okay, you really need an ultrasound and a mammogram to get an idea of what something is. And then if something looks suspicious, you need a biopsy. So sometimes men can get masses from what's called gynecomastia, and they can feel it behind the nipple. But an ultrasound is going to show that in a mammogram. So it's never good to just assume something is benign. It's really important to get that imaging. And again, if something looks suspicious, then you put a needle into it. Male breast cancer is generally treated the same as it is in women. More men choose a mastectomy because they don't have a whole lot of breast tissue, and they may want to avoid the radiation. They could have a lumpectomy and radiation, but they may want to avoid the radiation. So having a mastectomy isn't necessarily as much of a cosmetic issue, but we do talk about the options. We check the lymph nodes in the same way. And in terms of, do you get chemotherapy or not is made, again, based on what type of breast cancer it is. And then for hormonal therapy, they can take aromatase inhibitors. They can take drugs that block estrogen. And, the side effects in men is that it can have an increased risk of impotence, so that can be a problem. So, the important thing is that if a man has breast cancer, he should have genetic testing done. And that's important knowledge for his family members, because if he has a genetic mutation like BRCA1 or BRCA2, that could be passed on to other family members. But as with women, if you feel a mass, early detection is very important. Men don't get routine mammograms, so that's why if they do get diagnosed, it also is at a later stage.
I mean, that was fantastic. I have one final question for you,
Sure.
and I want you to tell me whether this is a myth or it's the truth. I have seen a lot of patients, female patients who've had a breast cancer, whether it's lumpectomy or mastectomy, coming to the clinic and said, "Oh, don't take blood pressure in my right arm because this is the arm, this is the site I had cancer with." Is there a consequence to it? Is that a myth, or is there some science behind it?
So it depends on what they had in their lymph nodes. So some people have cancer in their lymph nodes, and they have a procedure called a lymph node dissection where all of their lymph nodes are removed. And they are at increased risk for developing what's called lymphedema, which is a swelling of the arm. And so you want to avoid any type of trauma in that arm. And so we don't want blood pressure cuffs. But nowadays, the majority of women have a much less invasive procedure. Most people don't have to have all of their lymph nodes removed. There's a smaller procedure called a sentinel node biopsy, and that's where only a few lymph nodes are removed. And in that situation, they can have blood pressure cuffs. But a lot of our allied healthcare professionals don't know the difference. And so they'll tell them that they can't have it. So it depends. If it's a sentinel node biopsy, they're not really at high risk. If they've had a full lymph node dissection, they are. And the other thing is, if there is an emergency situation, someone is having a heart attack or something, it doesn't matter. Don't think about the arm, right? If it's an emergency, you can use that arm.
Well, thank you. Thank you so much. I think that brings us to the end of today's show. Thank you once again. Your dedication to advancing breast cancer treatment, both through clinical practice and innovative research, is truly inspiring. And it's clear that the future of such a terrible disease is in very capable hands with leaders like you driving the change. So, for the listeners, if you're looking for more insights in the latest in the breast cancer research and treatment, please be sure to follow Dr. DeMore's work and stay tuned for exciting developments ahead. Thank you for joining us on this incredible journey, and we look forward to hearing more about your progress in the in the fight against breast cancer. Until then, take care, stay informed, and make informed choices.
Thank you so much.
Thank you so much for listening. If you found us valuable, you can subscribe to the show on Apple Podcasts, Spotify, or any of your favorite podcast app. And also, please consider leaving us a rating or a review, as that helps others find the podcast too. I hope you have a great week ahead.